the practices across the country have all complied with CDC and government regulations. So I want to thank everyone from the start for all that you're doing, and those that are volunteering at hospitals and things, we thank you too. So again, my name is Dr. Charles Doring. I am a general dentist in the Rockville, Maryland area. I'm on the medical staff at Rockville Nursing Home and the Hebrew Home of Greater Washington. I'm also very proud to be your Maryland State Dental Association Legislative Affairs Committee Chair. I'm also on the Dean's faculty at the University of Maryland. Any questions that you may think of after this webinar, you can reach me. The best way is at cdoring@comcast.net, and that will get to me directly. We have about 500 people signed up for this webinar, so if you do contact me, I will try to get to you by the end of the week. So, next slide. So let me say from the beginning that of the things I am not a fortune teller, nor am I an attorney. Answer to questions may be, we just don't know, or please consult your practice attorney well-versed in medical dental law. Opinions and advice that I give are my own and may not be directly associated with the groups and associations I listed earlier. This course is 2 hours approved by the Maryland State Board of Dental Examiners and can be applied for your license renewal. The Maryland State Board of Dental Examiners recently lifted the 17-hour cap on self-learning courses, of which webinars like this are included, in those that are renewing their license in 2020. We're working with the state board because we feel, Maryland State Dental Association feels that much more learning is going to occur in the future by distance learning such as this. So we're going to try to expand and get our own category for webinars such as this. And last note is I'm a practicing general dentist with no financial interest in any products or procedures discussed today. And I think it's important to disclose any associations. So Greg, next slide. So I said I'm a general dentist, special interest in caring for cognitively impaired and medically compromised patients. No commercial or financial interest. Clinical pictures are my own, and procedures and techniques discussed are ones that I find helpful in my practice. I suggest you research and test any products prior to purchasing. Always use your best clinical judgment and skills in choosing dental products, procedures, and materials. Those are little denture, ceramic denture cups, holders from the late 1950s, early 60s that my wife found at an antique store. Greg, next slide. So let's get into COVID-19 and CDC guidelines this has all been recently updated as far as April 7th of this month. So contact patients prior to emergency dental treatment. I do stress with my office staff, we are open, but we are postponing all elective procedures. We're just providing emergency care. And it's very, very important to do this because we want to prevent patients from showing up in emergency departments and stressing those that are already providing care for COVID-19 any further. So the CDC guidelines specific for dentistry ask us to telephone triage all patients in need of emergency dental care, assist the patients, assess their condition, and determine whether the patient needs to be seen in your office. Use teleconferencing or teledentistry options as alternatives to office care. If dental treatment can be delayed, provide patients with detailed home care instructions and prescribe any appropriate pharmaceuticals. Next slide, Greg. So let me give you a brief, kind of interesting history on telehealth. Next slide. In 1948, the first radiological images were sent via telephone. It provided to be a useful tool for those who were maybe in isolated areas. Doctors started using communication tools to send radiological images to other specialists to speed up data transfer process. I will say from a personal standpoint, I sustained an injury on a finger several years ago and ended up at Montgomery General in the middle of the night. And of course they x-rayed my hand. And I said, I guess the radiologist, you're gonna call them in. And he said, no, we're sending the image to Australia. The radiologist there will review it and send back their findings. So this is done in practice today with electronic transferring of these images. Next slide. So we jump to 1961. The US space program conducts test flights with using animals and using remote medical systems. So this is a image from October 1961 of the first Saturn rocket launch from Cape Canaveral. And it paved the way for patient monitoring that's commonly used today. Next slide. Then we go to 1967. Telemedicine appeared in urban communities as well in the world of emergency medicine. The University of Miami School of Medicine partnered with local fire department in 1967 to transmit EKG rhythms over radio to Jackson Memorial Hospital. The image on your right is from the popular TV show in the 1970s, the drama called Emergency. For those that grew up during that era, you'll remember 2 LA paramedics using wireless communication to triage patients in the field. Then they showed how they wirelessly communicated with the emergency department and even showed transmissions over radio waves of EKGs. The show also introduced the public to the use of defibrillators. Next slide. So here we are today, and our state of Maryland, we're grateful to have the Maryland Health Commission. And this is an independent regulatory agency, and I recommend you visit their website. You just Google Maryland Healthcare Commission, and they can provide valuable information about IT health and efforts to modernize healthcare industry. Now you'll see their initiative is electronic health records, or EHRs. I will also in this presentation use the term EDRs, and that stands for electronic dental records. So anyhow, their initiative is to help in exchanging information through Health Information Exchange, or HIE, which is a secure electronic exchange of health information between providers. And just as an interesting sidelight, I've had several patients coming in previous to COVID-19, say for prophy appointments, and they said, you know, my cardiologist asked when my last dental cleaning was. So the exchange of information between dentists and physician and other medical health professionals is becoming more and more important as we see the systemic effects of the oral cavity related to overall general health. Telehealth is the delivery of health services using telecommunications and related technology. Next slide. So just for an example, what is CRISP? Well, that stands for Chesapeake Regional Information System for our patients. We're all familiar with that. For example, in use of CRISP, would be an emergency department when a patient would present maybe unconscious, but they're able to obtain the patient's ID. They could go through secure records and get the patient's medical history, medication that they're using, and other information. So another example of the use of CRISP that you may be familiar from the PANDA courses that we take is someone comes in with suspicious injuries, and this allows medical professionals to maybe track spousal abuse. So those are examples of the use of CRISP. Next slide. So within CRISP is our prescription drug monitoring program. Those of you familiar with the proper prescribing course would be very, very familiar with this. Now, I just checked on the CRISP website, the PDMP. This now includes Maryland, DC, and all surrounding states, plus 9 additional states and military health records. So the PDMP, I highly recommend any of your patients that you're prescribing controlled dangerous substances that you check the PDMP prior to giving those prescriptions or writing those prescriptions for your patients. Next slide. So here's an example that I use in my association with long-term care facilities, a software program called Point-Click Care, very commonly used in nursing facilities around the country. What I can do with Point-Click Care is I can write my clinical notes and share that with nurses, nurses assistants, physicians, dietary, speech therapy. They all have access, and this really improves the care. I can do orders on Point-Click Care. I can, for example, extract a tooth in the morning on a long-term care patient, and that evening I can check, how much did they eat? Are they experiencing any pain? Do they need any pain medication, for example? So this is an excellent example of electronic health records and health information exchange. Next slide. So I went back and did a little med search within JADA when really the first clinical study was done on teledentistry. And it goes back to 2003 in March, and an article called Teledentistry and Its Use in Dental Health from a variety of sources, Chen et al. At University of Texas Health Science Center. So the clinical conclusions was that teledentistry can extend care to underserved populations such as those in rural areas at a reasonable cost. And the other conclusion was teledentistry provides an opportunity to supplement traditional teaching methods in dental education and will provide new opportunities for dental students and dentists, and I would include at this point the dental team. Next slide. And then we get to just this past month in RDH magazine, you'll see the hygienist community talking about extending outreach through mobile dentistry and teledentistry. So this has really become a hot topic, and that's why we see such interest in this. Next slide. So let me get to put on my legislative hat and just go through some important legislation that's just passed recently. As you may know, because of the COVID-19 emergency, the legislative session, what we call sine die, ended almost 3 weeks early. So there was a great rush to move legislation forward. I will say, thanks to our great lobbying team of Fran and Dan Doherty at the MSDA and assistance through Beth Levine, we had a very good legislative session. And I'd be happy to go through that maybe in another seminar. But one of the bills that we did monitor very closely was this telehealth bill called Senate Bill 402 and House Bill 448. So we had 2 separate bills, and I'm just going to go through a little bit of legislative background, when two bills are submitted in each legislative body, they're filed and they're amended, and then they have to come back through a joint committee if there's different amendments that don't match up exactly, and come to a consensus and then pass the bill. And that's exactly what happened here on Senate Bill 402 and House Bill 448. And I want to say, you know, it's great to work with dentists and to meet legislators, and these are two very important movers and shakers in Annapolis. They're both members of the Senate Education, Health, and Environmental Affairs Committee. So these are two senators that we deal with many, many health issues. So these are the particular sponsors on Senate Bill 402 that really moved and progressed the legislation. Senator Cheryl Kagan on the left is from Montgomery County, and Senator Clarence Lamb, who also happens to be a physician and wanted to join us today, but he's treating patients at Hopkins Hospital right at the moment, and he wished us luck in our webinar today. But anyhow, these people were key in moving the legislation through both bodies and signature for the governor. So we can go to the next slide, Greg. So what exactly is telehealth? Well, it refers to a broad variety of technologies and tactics to deliver virtual medicine, health, and education services. As an umbrella term, it's further defined when applied to specific healthcare disciplines such as dentistry and hence teledentistry. Greg, next slide. So teledentistry, telemedicine include, but not limited to, the following modalities. And we're going to talk today primarily about the first two. Live video, which is considered synchronous, and store and forward in a cloud, and then reviewed later by the practitioner, is asynchronous. Other examples of telemedicine, teledentistry, might be remote patient monitoring. To give you an example of this would be, say a patient has a cardiac monitor, and then bedside, they have a wireless connection to a router that would send information while the patient's sleeping to, say, their cardiologist to monitor their heart condition. In mobile health, or mHealth, example here that I just learned of recently from a patient, a young adolescent patient with diabetes and dependent on insulin, is he has an insulin pump that has a wireless to his mom's cell phone. And so she can continually monitor, it will send alerts whether his blood sugar gets into a dangerous level where he may need more insulin or to eat some food, for example. It's interesting, the mom was explaining this to me. Once, if schools were open and he was in school, the mom would get an alert and then she would contact the school health nurse who would take appropriate action. So that's just an example of mHealth. But again, we're going to focus on the first two. Next slide. So back to the bills that we were discussing, particularly Senate Bill 402. And you see here the bill signing. On the left is Senate President Bill Ferguson, and the center is our governor, Lawrence Hogan, and on the right is House Speaker Adrian Jones. Now, typically, and I've been to several bill signings, these are very joyful occasions with many people present, signing the bills, shaking hands, congratulations. As you can see, with social distancing, and this bill was just signed on a little over 10 days ago, that this important legislation, you see April 3rd it was signed, how important social distancing is. So next slide. So let me go over the provisions in this Maryland bill. And there are some people perhaps listening from outside of Maryland. So I encourage you to check your state's provisions and laws concerning telehealth. Now, I also will say that this bill, although it's a very important and great bill, it is still being reviewed. And this is why I don't know a lot of answers to some of the questions that may come up. This is being reviewed by our health department, although they were involved in the drafting of the bill. They may have particular analysis that has to go further. The bill is also being currently reviewed by our Maryland State Board of Dental Examiners. That's the group that issues our license and is responsible for the safety of all Marylanders as far as dental care that's provided by us. So do check your particular law if you're not practicing in Maryland. So provisions on this bill is you must be a licensed health care practitioner. Patient must be in a different physical location. They could be at home, they could be in a nursing home, but they're not in your office. Telehealth does not include solely audio-only calls, emails, messaging, or facsimile transmissions. So those are not included in telehealth. Next slide. So doctor-patient relationship is spelled out in this new telehealth law. Practitioners must verify the identity of the patient, and I'll get into that in more detail as we go. Practitioner discloses to the patient their name and their health occupation license that's held. So for example, if it's a patient I have not met before, I would introduce myself and that I'm a licensed dentist. Patients that you've already known in your practice, so perhaps you're screening an emergency, would know that, but I would still disclose that. And you want to obtain either oral or written consent from a parent from the patient or the guardian. This little cartoon, believe it or not, is from April 1924. So almost 100 years ago, radio news, a little cartoon shows the radio doctor, and then maybe shows a little boy inserting his arm into this device where they're measuring his temperature and his pulse. And you can see the doctor on the little screen. So this is, was probably thought to be very far-fetched in 1924, but is becoming reality today. Next slide. So more on the new telehealth law. Practitioners, and this is very important, practitioners are held to the same standard of care that are applicable to in-person healthcare setting. And I'm sure Dr. Bob Wilson will go into this in more detail. If appropriate, provide or refer a patient to in-person healthcare services. So if you interview a patient via telehealth or teledentistry and you say they really do have an issue where you need to see them, you can do so under the CDC guidelines. Or you can refer them to another type of health service. Say they need to see their physician, or you could refer them to your local endodontist. Those are all options. You must perform clinical evaluation before providing treatment or issuing a prescription. And I'm going to show you how you can do kind of a cursory clinical exam through teledentistry in a little video clip coming up. Next slide. Telehealth prescribing restrictions. This is the issue where a lot of the amendments in the bill and a lot of discussion, because we do have an opioid crisis in Maryland and across the country, and they didn't want telehealth to contribute to that. So under normal circumstances, we may not prescribe opiate listed in Schedule 2 unless the patient lives in a healthcare or resides in a healthcare facility, such as a long-term care facility, or the governor has declared a state of emergency due to catastrophic health emergency, like we are currently going through now. Next slide. So some of you that have taken my proper prescribing course will remember the Schedule 2, and this is a list of the drugs that if you want a comprehensive list, go to FDA.com. But this would include OxyContin and oxycodone that would typically you could not prescribe off of a telehealth session. Next slide. So telehealth law documentation. Also in the law, you must document a patient's record of the healthcare services provided through telehealth, according to the same document standards used as an in-person healthcare services. So documentation is so important. Confidentiality and patients' rights to health information apply to telehealth interactions the same manner as in person. So your HIPAA regulations, and I'm going to talk about this in an upcoming slide, but as far as confidentiality, if you do do a teledentistry appointment with a patient, you want it to be in a nice quiet location. Obviously, say if a Starbucks was open and you did a teledentistry consult there with other people around, that would be a HIPAA violation. So I just want to remind people that you're under the same constraints as a patient in your office. Next slide. I want to bring up one other important bill that passed this year that's going to impact all of us who write controlled dangerous substance prescriptions. And that's Senate Bill 116 and House Bill 512. Now, with very few exceptions, all controlled dangerous substance prescriptions, and this would include diazepam in many jurisdictions, be submitted electronically to pharmacies starting in January 1st, 2022. And those that are submitting under Medicare, that starts earlier under federal mandate, January 1st, 2021. The MSDA had concerns, and that's why we had this rolled back a year on the start to 2022, because we know many of our software vendors are not set up yet to do electronic prescribing. So I just wanted to make that you all aware that that is coming down the pipe. Next slide. So I wanted to talk about the notification of enforcement discretion in telehealth due to the COVID-19 national emergency. Some of the technologies and manners in which they are used in telehealth, HIPAA-covered healthcare providers may not fully comply with the requirements of the HIPAA rules. Now, I'm not talking about confidentiality doing the meeting in a public place. I'm talking about more of the electronic requirements of enforcement here. So the Office of Civil Rights, which would enforce the HIPAA regulations, will exercise its enforcement discretion and will not impose penalties for non-compliance with the regulatory requirements under HIPAA rules against covered healthcare providers in connection with good faith provisions of telehealth during the COVID-19 nationwide public health emergency. This notification is effective March 30th of this year. So as you see, they've relaxed the requirements. What does that mean for us? We can use platforms such as Zoom that you're on now to correspond with our patients. But when the health emergency is declared over, we're going to have to use more secure means of communicating with our patients. Next slide. So I recommend, and I know you're getting 2 hours for attending this course. I'm going to let you in on a secret here. If you go to ada.org and /COVID-19, the ADA has a tremendous amount of information about COVID-19 that I strongly encourage everyone to take a look at. Included in that information is a 1-hour webinar where you watch a video and answer 4 or 5 questions, and you can get another hour of CE this way. So if you go to ADA and these guidelines are part of that COVID-19, and you can get more information, get an additional hour of CE. So there are 2 CDT code entries. The D9995 Teledentistry, which is synchronous or real time. And then you've got the D9996 Teledentistry asynchronous, information stored and forwarded to a dentist subsequent for review. Next slide. So let's go into more specifics. Synchronous teledentistry is delivery of patient care and education where there is live 2-way interaction, such as right now I'm communicating with you, between person to person, patient, dental, medical, or health caregiver at one physical location, and another overseeing, supervising, consulting dentist or dental provider in a whole separate location. Communication is real-time and continuous between all participants who are working as a group. Use of audiovisual communication technology means that all involved persons are able to see what is happening and talk about it in a natural manner as if they were in your office. Next slide. So asynchronous is not real-time. And it's usually information stored, such as photographs, x-rays, charting, and then reviewed by the healthcare practitioner at a later date. Pinto micrographs, for example, say in oral pathology, and you're looking at slides under a microscope, that would be an example. If that was in a consult from, say, an oral pathologist to a dentist, that would be and looked at and reviewed at a later time, an example of asynchronous teledentistry. And these have all been updated. They've been in the CDT book for the past couple of years, but this has all been updated since March 2020 by the ADA. Next slide. Reimbursement policy. And I'm sure Dr. Cheryl Lerner will go through more of this in greater detail. But this is the ADA policy that was adopted in 2015 concerning teledentistry. Dental benefits plans and all third-party payers, both public and private programs, shall provide coverage for services using teledentistry technology and methods delivered to covered persons to the same extent that the service would be covered if provided through an in-person encounter, just the same as if they were in your office. Coverage for services delivered via teledentistry modalities will be at the same level as those provided for services through in-person encounters and may not be limited or restricted based on technologies used or the location of either the patient or the provider, as long as the healthcare provider is licensed in the state where the patient receives services. So again, that's the policy. That may not be the policy of the insurance companies, but this is what the ADA is striving for. And if you go to the ADA's website, they update daily on what different insurance carriers, as far as reimbursement, is providing. As they get that information from the insurance carriers, they are updating that on their website daily. Next slide. So in the coding, you would use those codes mentioned earlier, the D9995 and the D9996, in conjunction with other codes for services you provide. So for example, you could do a limited exam problem focus. This would probably be your more common one during this COVID-19 period. You could have an example of a D170, or reevaluation or limited problem focused on an established patient. Say you had a patient you saw and you put in a crown, and then maybe the bite was high and they were a little sore, so you did a teledentistry consult to kind of check on them. So that would be a reevaluation in a sense. And then the D171 is reevaluation post-operative. Say you did a periosurgery flap procedure and you wanted to reevaluate, or you're in the middle of an orthodontic case and you wanted to see some photographs that way. You could do reevaluation. Although many times in orthodontics, that's considered part of the ongoing treatment. So not necessarily generating a new bill for the patient. There's also codes for dental case management, care coordination. So you had to correspond with the patient's physician or dental specialist and the patient all at the same time. You could use that code. Plus any other additional procedures, diagnostic, delivered to the patient on that same data service. So if they were, say, in a long-term care facility, and you were using Nomad to take x-rays, you could also bill for that. Next slide. So specific for those providers that are in the Maryland Healthy Smiles Dental Program, our state Medicaid program, this is the announcement that came out in March that they will do reimbursement for teledentistry, and they suggest bill placement of service use the code 02 to indicate telecommunications technology. And they specify this is not communication by telephone. This is via seeing the patient one-on-one over the internet, such as Zoom. No prior authorization is needed. Use of procedure code D140, as we mentioned before, the limited exam. Their reimbursement rate for this is $43, and I'm not sure why they came in for 20 cents, but that's what it is. So that's information for those that are in the Maryland Healthy Smiles. I will tell you that the MSDA just got a letter from the health department that the state of Maryland has included in its budget for next year for 60 days postpartum coverage for those women that give birth. Usually under the Maryland Healthy Smiles program, the day that the patient in the program delivers, dental benefits stop. The MSDA and other groups have said, well, we really need to treat these women after the patient delivers the baby, and so the state has agreed to additional 60 days, and we thank them for that improvement. Next slide. So teledentistry consent suggestions. And again, I'm gonna ask that you review this document with your attorney, your practice attorney. This is a suggestion from Dr. Nathan Suter, who's on the webinar on the ADA website. And you can get this from the ADA. I, right now, am not recording my conversations through telehealth, teledentistry with the patient. I think that opens up other issues. You certainly, if you do record the session under Maryland state law, you must disclose that. And again, I would review this consent document. And the law stipulates it can be oral as well. But if you provided a statement like this and you wanted it signed, I would email it to the patient prior to your telehealth visit and have them sign it, scan it, and send it back to you. I do think it's always best to have things in writing. So if you want this document, again, it's on the ADA website. Next slide. So progress notes, as I stress, documentation is very, very important. So the originating site could be the patient's home, office, or school, or say it's a patient in a nursing home. So you would list where the originating site is. Who is the patient presenter? Is it the actual patient, which many times it is, or is it a caregiver, a charge nurse, a dental hygienist, or other provider for the patient? The distant site is defined as the office or provider home address. And then you want to list the methodology, whether it's synchronous or asynchronous. And then you also want to note any diagnostic imaging, photos, videos, and you want to refer back to your patient's existing electronic dental record. So I would note if I'm doing a teledentistry session with a patient, I would note in my records that I went back and I reviewed their health history and updated that. I reviewed their most recent radiographs. I reviewed their periodontal charting. Anything like that you want to document that you reviewed. Next slide. So part 2 on the progress notes, screening and triage during COVID-19 pandemic. You want to ask your typical screening questions that the ADA has on their website and review their current medical history. Obviously, you want to get their chief complaint, your observations. You want to make a note of your clinical impressions or your differential diagnosis. What could the issues be that the patient's presenting with? And then you want to coordinate your care. Do I need to see the patient urgently in the office? Do I want to refer them to a specialist, to their physician, to an oral surgeon, to an endodontist, for example? Do I want to write a prescription and follow up in a day or two? This is often a good way of doing things, so you want to document that. And if it's not an urgent thing, you want to do a waiting list. Now, I know our patients want to know when we're going to open back. We don't know. It's not up to the MSDA. It's not up to the ADA. It's up to our health department and our healthcare infectious disease persons like Dr. Fauci. So we're all in a waiting period. We just don't know. I suspect we're going to be getting into a busy period once we do get into a more normal situation. So you want to have a spreadsheet because you may not actually schedule the patient, but you want to set up a method so that you know, okay, that patient's waiting to come in. They did contact us. It wasn't an emergency situation, but we do want to follow up with them. So I would recommend you do that. Next slide. So how do I get started? And again, this is keeping in mind the waive penalties for HIPAA violations as far as electronic communications during the COVID-19 pandemic. There are commercially available applications through electronic devices. You can use what's termed non-public facing apps, such as Zoom, FaceTime, or Skype. You do not want to use Facebook Live. You do not want to use things that are open to the general public to see. Check with your office software vendor and secure HIPAA compliant platforms that you can add to your existing software. I know, for example, in my office, we use SoftDent. So CareStream actually later on today is having a webinar on their teledentistry platform that they're coming out with. Also, at the same time, when you're talking with your software vendor, check on electronic prescribing while you're at it. Since that's going to be a must in a year and a half, you might as well get the software update you need for that. When you're talking to these vendors, you're going to have to inquire, obviously, what is the additional cost for these services? What are the amount of services they're providing. And is that cost, say you're in a multi-doctor office, is that cost by provider or is it by office? Those are important questions. And I do want to stress that you do want to check with your malpractice carrier about any conditions that you're providing teledentistry. We do think I've did some research and talked with several people the past few days about this issue. We do think it's important you notify your carrier. We do not at this point think it puts you at a substantial additional risk with your malpractice carrier, but it's best to be informed and to notify them as well. Next slide. So just some examples of teledentistry. I'll give you 4 examples. This is a Zoom conference with a 47-year-old healthy male, and he's felt some swelling behind his upper right front teeth. And so he sent me a photograph. It's not painful. It's rather firm. And so I shared the image with him and pointed the cursor at this mandibular tori. And I said, "Is this what you're talking about?" And he said, yes. And he said he never noticed it before. And I think that's something we've always encountered in our practice. So I assured the patient no treatment was indicated and will follow up at their next dental visit. And I put their name on the spreadsheet. Next slide. Example 2 is a Zoom conference with follow-up by telephone. This is actually an interesting case where it's actual physician who moved out of the area. Their family had been a patient of mine for a very long time. And so she moved out of the area and she contacted me, burning tongue and mouth. The burning sensation was worse in the morning. She consulted with her primary care physician and dermatologist, and they tried various mouthwashes and things, and was no resolution. So I spoke to her and I suggested we discontinue toothpaste with sodium lauryl sulfate, the antibacterial detergent used in many common brands of toothpaste. And she did that for a week, 10 days with no improvement. So we discussed again. I said, you know what, it really sounds, it doesn't look swollen, but I understand how uncomfortable you are. Let's do a referral to an allergist to do some allergy testing. And it turned out she was in fact allergic to the spice cinnamon. And once she discontinued use of Cinnamon Crunch cereal, her burning mouth syndrome resolved. Next slide. Example 3, a Zoom conference with follow-up phone call after an office visit. I was able to remotely access the patient record. It's a 35-year-old female with a recently completed endo on tooth 19. She felt her tooth was breaking apart. And in fact, as you can see on the radiograph, heavily restored tooth number 19 with some kind of temporary filling on the distal buccal lingual. And I too was concerned of a possible fracture in the tooth. So after conferencing with her, I said, well, let's schedule a time in my office, bringing in a dental assistant. I do think it's very important that you not see patients in your office by yourself. I can't stress that enough. We do have limited staff. Dental assisting team is rotating during this crisis. So we brought in a dental assistant, and with high-speed suction and appropriate masks and minimizing aerosol, I just carefully trimmed interproximally, placed an orthodontic band, and took the tooth out of occlusion. Patient is extremely happy and gratified that she's lessening the chance of fracturing that tooth. And then we'll bring her back afterwards to go ahead and appropriately restore the tooth with the crown. Next slide. So here's my final example, and this is pre-COVID-19. Because of my association with long-term care facilities, I do use general supervision to send the dental team out to long-term care facilities. There's provisions in the law to do this. And so I use asynchronous communication with my dental team and the long-term care facility at a local nursing home. So this is a 95-year-old male with buccal swelling on the lower right, noticed during a hygiene visit at the nursing home. My dental team sent over digital imaging. I was able to access through electronic health records and exchange the medication list, reviewed everything, scheduled an extraction, performed at the nursing home, and then I was able, through healthcare information exchange, to monitor the patient's recovery. So this is another example of teledentistry. If I were to do this again during COVID-19, I would probably prescribe antibiotics for this patient and closely monitor, and if we had to, extract the tooth at that point. Next slide. So let me go through the process. The patient is going to contact your office one way or the other via a phone call, an e-message, or something that they have an issue. Next slide. So preparation. So they're going to contact your office, and you're going to want to determine, is this a new or existing patient? And you can decide whether you want to accept a new patient or not. I personally feel, especially at this time of the crisis, that's important to take care of all our patients, whether we've seen them before in the past, but that's really up to you. You want to, by phone, triage and maybe set up the dental consult via the internet. You know, is this going to be a follow-up from previous therapy, or are you going to triage the patient? Now, I like to set up a time, an appointment time to, set up a Zoom time to meet with the patient. I will email them prior the consent information. I'll also send them a little list of things that I feel that they're going to need to have next to their computer to make my exam easier, and then a confirmation with a link to that meeting. So to try to prepare things as much as possible. A week ago, my wife had a telehealth with her physician, and what they did was they called, and I spoke to them prior. They wanted to know if we were familiar with the process. I said yes, and then they collected the copayment at that time. So request that the patient have a flashlight and 2 spoons handy, and I'll get to the spoon trick in a moment. Request patients have a family member to assist holding the phone if they're taking pictures. Next slide. So on that appointment I mentioned about my wife, the physician was about 30 minutes late. So my poor wife was standing in front of a blank screen for 30 minutes. I do think it's important to be on time if you set, or if you run into another emergency, call and let them know, hey, I'm going to be a little late. You do want to dress and have a good demeanor. You're representing yourself, your practice, and the profession. You want to have a good work environment, good lighting and sound, a good Wi-Fi connection with bandwidth. This on the left shows how I have it set up. As I have it set up right now, 2 computer screens, I like that best. Or you can use one screen and browse back and forth between your patient interview and the patient's record. I also take copious notes. I have a bottle of water. I have my cell phone handy in case the patient mentions maybe some medication I'm not familiar with, and I can quickly look that up as well. Next slide. Okay, so the patient's virtual appointment. I would do things very similar as you do in your office. Verify the patient's identity. ask questions, just like if you were calling your credit card company or your bank on the phone, they want to identify your identity as well. Date of birth, a photograph is helpful, address, things like that. Update health history, including all prescriptions, including over-the-counters, herbals, patches, and inhalants. Review the patient's chief complaint and history of present illness. Review of systems. Could things be related to a cardiac condition or a respiratory issue or a GI? So review their overall health and systems and do a virtual clinical exam. Next slide. So virtual infection control. If a staff person is with you during this interview and you're not social distancing, I would wear a mask. And this is what occurred when my wife had her appointment. The physician had a medical student with her taking notes, and they were both wearing masks. So that's very appropriate. Instruct patient on proper hand washing, particularly if they're using their hands and their mouth to retract soft tissue. This is why I like the spoons. Keyboard protection. It's good to periodically wipe down your keyboard as you do in your office. And not related to viral in the sense that we're going through now, but do update your antiviral software on your computer. There seems to be, I've noticed, a tremendous amount of internet phishing going on. So please do not open any attachments or links from people you do not know. Next slide. So the trick with two spoons. I want to thank orthodontist Dr. Jesse Isaac for this little video clip. Now keep in mind, she's an orthodontist in the Baltimore area, and she's recording this to give to her patients to chart their progress as they're going through their orthodontic progress. This is not really they may do a telehealth section in coordination with this, but this is just to illustrate to you what you can do with two spoons in doing an oral exam in telehealth. Greg?
Hi everyone, Dr. Jesse here. We have Allie with us as well. Over the next few weeks, we'll be asking you guys to take some pictures so we can monitor your progress. A picture is worth 1,000 words. It's the next best thing we can do other than seeing you guys in person. So we're going to walk you guys through some steps on how to take these pictures. We're going to use Allie as a demonstration, but everybody's going to need two things. We need two spoons to do that. So it's very important that when you're taking these pictures, you do your correct bite. You want to bite on your back teeth, not your front teeth like this. You do not want to do that. You want to bite on your back teeth. Perfect. All right, so the first picture we're going to take is a front shot. I'm going to use your two spoons to pull your lips apart, lips and cheeks apart. Perfect. It doesn't matter which left or right you start with, but we want side pictures as well. The side in which you're taking a picture from, pull that spoon out more and take the other side spoon and loosen the tension so that the correct cheek can be pulled out. And then switch sides, repeat the same process. Try to take the picture as perpendicular as you can to get the best, most unobstructed angle. Perfect. And then we're going to try to get the upper teeth, come from under the teeth as much as possible. Perfect. Open big as you can. Perfect. All right, now same on the lower. Try to get as directly above the teeth as possible. Wonderful. Great job. Okay, so we're going to also be posting some examples of these pictures for you guys to see sort of what they look like. We appreciate your help. Thank you so much.
All right, so Greg, you can go to the next slide. I actually used that system over this weekend on a young 28-year-old male complaining of tooth pain on tooth 18. A lot of times for younger patients, I think wisdom teeth, but he had his wisdom teeth removed. But I was able, with the spoon trick, to clearly see all the way back to tooth 18, there was no buccal swelling. So documentation, again, same as for your office patient. I use SOAP notes, symptoms, observation assessments, and then a plan of action. And I also like to follow up a phone call or another virtual appointment. So I kind of end the session. I give the patient my personal cell phone number because if their condition gets worse, I instruct them to call me right away at any time, day or night. I also ask them, did you find this virtual appointment helpful? And often they do. But as a matter of fact, I've never found anyone that didn't like it and found it useful. Next slide. So your progress notes, because it's teledentistry, need to include the origination site. Again, could be the patient's home most usually. Patient presenter, was it the patient? Was it the mom, a spouse? The distance site, you know, is this your office or your home address? The methodology used, synchronous or asynchronous, and any diagnostic imaging and things that you reviewed in your notes. Do note that in your electronic dental record. Next slide. Plan of action. Does the patient need emergency care? Do I want to refer them to a specialist? And I would make things very easy and coordinate referral. I'll text or email the endodontist and said, when would you be available to see the patient? And I would coordinate that appointment for the patient. Go out of your way. It's the little things that count. Do we do a prescription? Is it an oral home care issue? Take corrective action. Are they doing floss cuts, for example? Things like that you could see on an image. Specific follow-up. I'm going to follow up with you at 10 a.m. in 2 days, for example. Give patient your contact information should the condition worsen. Next slide. And as I said, this is Coach John Wooden, who had a string of men's basketball titles at UCLA. And it's the little details that are vital. Little things make big things happen. So do the utmost for your patients. Next slide. So my prediction for the future, I know we're going through a rough patch here, but I do think things will improve. Teledentistry is going to be a new and exciting tool we can use to provide better care for our patients. Teledentistry will improve access to dental care to remote and underserved communities. Teledentistry will allow the dental team to go out into the community and communicate electronically with the supervising dentist. Also feel that telehealth, electronic health records, and health information exchange will improve communication between healthcare providers for better outcomes for our patients. This picture on the left is my dental team, Laurie, dental hygienist providing care on the elderly patient we typically set up in the beauty salon at Rockville Nursing Home. Jesse, the dental assistant, and I've got 2 dental students on rotation observing and assisting. Next slide. So I end my part of the presentation. I want to give a special thanks to the American Dental Association, Mr. Greg Buckler, who did the introduction, who's been up many, many nights helping to pull this all together in very short amount of time, and the MSDA staff that he directs. I'd like to thank the doctors and the staff at my office at North Bethesda Dental Associates. A big thanks goes to Alana Sutherland. She's the program manager at Maryland Healthcare Commission. And as I said, do visit their website for more specific information on telehealth in Maryland. Next slide. So this is a quote from Michael Jordan. Obstacles don't have to stop you. If you run into a wall, don't turn around and give up. Figure out how to climb it, go through it, or work around it. And we do these things. You can see how kids are getting through this kind of difficult time with a little bit of humor. Next slide. So at this point, I'm going to turn things over to Dr. Cheryl Lerner. Dr. Cheryl Lerner has earned both her BA and her DMD at the University of Pennsylvania and completed a GPR at Albert Einstein Medical Center in Philadelphia. prior to practicing and teaching part-time at Penn Dental School Clinic. She relocated to the DC area where she established a private practice and raised her family. She moved to an administrative side of dentistry in 1995, worked with several insurance carriers as well as the dental board in Maryland. She has taken on various responsibilities working with claims reviews, quality assurance, and network management, and in her current role as the dental director at CareFirst. She strives to ensure that oral health is given the appropriate attention as a clinical part of the overall health of the patient. She is also on the MSDA Foundation board, and she's program chair for the American Association of Dental Consultants. So at this time, I'll turn things over to Dr. Lerman. Thank you.
Thank you, Charlie. That was an amazing lecture that you gave us, and I've been to several of yours, and it's just as good as any other one I've experienced. So thank you. I learned a lot during this lecture and in the preparation of our combined lectures, and I can't thank the MSDA enough for doing this for my colleagues, the dentists in the state of Maryland and possibly beyond. So I am a general dentist by license, and I'm not an expert on teledentistry, at least not yet. We're in a learn as we go kind of mentality today, but as Charlie mentioned, the future potential of telehealth, whether for medicine or dentistry or possibly veterinary medicine, it's going to be amazing. And I think we have to look at the silver lining of all of this, how this will become something that we are able to take and move forward with the future in support of the better health of our patients. I also want to disclose that I don't have any financial obligations, but I am bribing my dogs to keep them quiet. So if you do hear them bark, it just means it's time for another treat. Also, some of my best friends are still practicing, and they are suffering financially and a little bit mentally through this crisis. So I completely have all the feelings that everyone else is feeling on this call. I do advocate for both the patients and the dentists in my role at CareFirst, and to ensure the safety and relief of pain for the patients and the safety, of course, of you and your staff. So thank you for making all of the modifications you've made so far to your practices during this crisis on behalf of your staff and your patients. It is important to note, though, that the alignment with the ADA and the government restrictions, we are definitely providing coverage from the insurance perspective for services through teledentistry as if they were rendered in the office. And that's really the message I want to get across today. So next slide, please, Greg. So why are we doing it now? Well, I think it's probably pretty obvious to all of us at this point that the government is giving us guidelines, regulations, recommendations to stay in place and to treat only the emergent and urgent care in your office. We're stressing the hospital systems, all the healthcare systems with all the emergencies that come in, and dental emergencies, which we all know can't truly be treated in an ER, we should try not to send our patients there. Therefore, there's been some relaxation of the image and document sharing, as Charlie talked about, and you can use your cell phones and video chat apps on all your devices to communicate in real time with your patients. We have higher resolution cell phone cameras, and there is a scarcity of the appropriate PPE, I'm hearing from quite a bit of my friends. So for that reason, we need to be focusing on telehealth, telemedicine, teledentistry. Next slide, please. So the question I want to answer is what is covered, and also how you can submit and get paid for services that you render through telehealth. As you know, the ADA does keep lists that are updated constantly. I was on the phone with them through 5 o'clock on Friday, giving them the updates for CareFirst, but all of the major carriers are chiming in and letting the dentists know what is covered and how to submit for it. So I'm going to speak specifically about CareFirst, but we're pretty much in line with many of the other carriers. The key procedures codes that we're talking about today are the D0140, which is the problem-focused evaluation or emergency exam, and the D0170, which is the follow-up on that problem-focused issue, only because you can't follow up or do that evaluation in your office today under the restrictions that are in place. So typically these examinations require you to have direct visual view of your patients and some tactile abilities so you can touch and feel your patients in areas that are bothering them. You can watch their facial expressions in 3 dimensions, and you can have radiology available to you, either x-rays or CBCT. So because these can't be done in office and we do want patients to be taken care of, we're looking at this more as kind of a triage at a very high level. So we relax some of these and allow indirect visual examination through the telephone, through a cell phone, through the apps. We are looking at the synchronous communication only as it's covered. And I believe Charlie had mentioned what the government had said about that definition for synchronous, and how it's more than just somebody sending information back and forth. Next slide, please. So what's not covered? So if you're getting photographs or you're taking screenshots, that's considered similar to you being in the office, and you wouldn't charge separately for looking at the right side versus the left side, intraoral or extraoral. You can keep clicking. Thank you so much. So you're replacing the in-person view that you would already be doing in the office. And again, remember, we're just trying to mimic what would be done in the office and take it to a telehealth perspective. So the fees for any equipment or programs that you need to perform this, payment for internet or cell phone, or if you're using an app or a part of your program that's part of your PMS system, third-party programs such as Shine's MedPod or Patterson has Opera DDS, those kind of teledentistry programs, yes, there's a cost to them, but it allows you to expand your practice. So that's not something that will get covered through insurance. Any other procedures that you're doing through telehealth, we're not really sure how you could do a prophy, but I have literally seen a claim come in for a prophy with a telehealth code. But the full examinations on a recall or an initial patient comprehensive exam, that's not what we're looking at during this crisis. We are really focusing only on the emergency and urgent treatment. So if your procedures that you note as necessary are rendered in your office, even later on that same date, submit a separate claim, because you're going to have an in-office claim and you're going to have a telehealth claim to take care of that same patient. Next slide, please, Greg. So how would you submit? Well, for the telehealth visit, again, remember in Care First world, we are only accepting synchronous communications. So we're only counting that for coverage. Now, if somebody sends you something in advance through email or a text message, they send you a picture of an area that's bothersome to them, that's great. You can put 9996 on your claim form, but you have to have a 9995 synchronous conversation with them discussing this piece of information that they have sent you. So on your claim form, you're going to put the date of service when you had the discussion with the patient, not when they sent you the information. You're going to put the evaluation codes that's appropriate, and likely it will be a D0140. In the place of service field 36, put 02 to indicate that it was telehealth, and apply your 9995 synchronous code. Again, if you also did a 9996, you can put that in, but our claim system, we will not process it if you did not do synchronous conversation with imaging with the patient. In the remarks section, please include just a brief statement of what the patient's issue is. Like Charlie had somebody with the mandibular torus. So a patient had an issue with an exostosis in the lower left mandible, something like that, or severe pain to biting on number 14. And that's what your conversation is about. Put your usual fee for the D0140. And if you have a code in your system for 9995, that's fine. You can put it, but I'm going to tell you that code will not be billable and not payable. The 0140 and 170 will be paid based on the allowed fees and any exclusions and limitations in the patient's plan. We have very few patients who have exclusions and limitations or co-payments of any type for the emergency exam, but there occasionally is. So just make sure you understand that, and please be patient and perhaps not bill that patient for the difference until after you get back your notice of payment or your EOB. The 9995, again, it's not a billable service. It's considered just a descriptor from the insurance perspective of how the services were rendered and where they were rendered, not which service was rendered. And we cover services that were rendered. Hope that is as clear as I can make it, but feel free later to ask me questions about it. If you're going to prescribe an antibiotic or a pain reliever, that of course is included in the evaluation, and it's considered inclusive and doesn't have a separate charge. Next slide, please, Greg. If you have an in-office visit that's subsequent to the telehealth visit that you have with your patient, you can submit a claim form exactly as you would any other in-office dental treatment. If you're also performing additional examination procedures that same day, you're not going to be paid again for an 0140 or an 0170 because we will have paid it during the telecommunication portion on that day. The place of service in field 36 is now 11 for the office. Do not submit a telehealth code because it's not telehealth. And note in your remarks section that this is an in-office visit subsequent to a telehealth communication. And you can also put tooth number 14 had pain to biting, something that just indicates what you did. It will be helpful for you in addition to your progress notes that you have this information on your claim form. Your usual fee for each line item, each procedure that you've completed. And we're looking at procedures, for example, delivering a restoration that you'd already had in the lab and the patient is in pain and needs to have that restoration in there. Completing a procedure that's a multi-visit one, such as possibly endo, replacing a large or broken filling crown tooth, some I&D and extraction as Charlie had gone through, anything that makes sense that's emergent or urgent. That's what we're looking for. If we start to see things like routine exams, we may be questioning dentists who are submitting during this COVID crisis. And the date that we would probably start looking at that might be, I think it was March 17th that we decided that we were going to look at COVID crisis. So you may get a call from us or a denial. You're welcome to appeal it, but just letting you know, we're expecting you to follow the regulations per the government as far as treating only emergent and urgent cases. Next slide, please. So some people have asked me what would be an appropriate charge. Well, we are paying for the full-fledged emergency problem-focused exam, even though we know we can't have all of the information at the dental office that we would normally have. We can't have it in a telehealth visit. So just to give you a sense of how much providers are getting paid for some of these things through third-party teledentistry companies, they get paid about $20 for a 10-minute complete case review, and that's obviously asynchronous, or $5 for a direct care case when you're just looking at that patient. So that's pretty low cost or low fee that you would be getting. So I think it's great that we are allowing some relaxation of the rules for the full coverage of an 0140. Next slide, please. What's the expectation of a telehealth dental visit? Well, we think it's more, and we know it is from all of the language was discussed before, it's more than just a typical call from a patient who's in pain and is seeking you to triage and appoint them for something. Typically when you get that, it's to be kind and to figure out how much time and when and how soon you need to get a patient into the office. But in this crisis, we can't get patients into the office if they're not specifically emergent. So we use visual aids to triage this case. We advise the patient on the next steps as the examples that Charlie gave. We can prescribe appropriate antibiotics or pain medication based on what we see during this telehealth visit. We're able to schedule the emergency exam as needed or refer to a specialist, the ER, a physician. We can also screen, and I think this is important, for the COVID-19 symptoms over the phone. We're able to provide the sense of comfort and familiarity for the patients of record, and even those patients who may not be your patients, you're able to give them a dental perspective, which is something they cannot get in an ER. Next slide, please. Just on Friday late in the day, we carriers received requests to discuss a couple of these points for future looks at telehealth in dentistry. Could we look at temporary procedures as not, could we unbundle them and pay for them because we don't know how long this crisis is going to be? Could patients who don't have out-of-network benefits get some coverage if they don't have a dentist in their network somewhere within distance and they do telehealth or they do a visit? Could infection control being so much more expensive during this crisis, could we look to possibly cover that? Could we relax some of the frequency limitations, especially for those cases I told you where there are member copays? Could we look at telecommunication technology? Could we create some rules about when to use it, how to use it, so that there's a better triage and evaluations, maybe for remote patients, maybe for rural patients? All this future possibility is definitely worth discussing. And COVID testing, if in the state of Maryland or DC or Virginia, Pennsylvania, if we were to have the scope of practice that would include COVID testing in the dental office, would we look to cover it? And it wouldn't surprise me seeing some CDT codes pop up for possibly immediate use, if that's even possible through the system. However, these requests, while great, have just come out on Friday, and these are things we're going to need to discuss in the carrier world to cover for patients and for the dental providers that we have. So just wanted to share that with you. Next slide. And that's really all I had in particular. If you have any questions, just put them in the Q&A section in Zoom, and we will be sure to get back to you. If you want to reach out to me, my email down there is really the best way to get it, cheryl.lerner@carefirst.com. And I'm happy to speak with anybody who has questions. Thank you so much. And I move on to Bob Wilson, who's going to share some more information about some of the regulations.
Thank you very much, Dr. Doring and Dr. Lerner. It's a pleasure to be with you this morning. I'm going to look at the ethical implications a little bit. I'm going to try to do this real quick so we can get to some questions. Next slide, please. That's my picture in the middle. That is my daughter's graduation from the University of Maryland School of Dentistry, a very proud day for me. And my other daughter, who also works in my practice. So our name for our practice is Wilson Family Dentistry, and it means a lot to us. So all the things on the bottom are a few things I've done. Right now, I'm vice chair on the Council of Ethics, Bylaws, and Judicial Affairs. But what's above my name, the picture, is what I'm truly proud of, even though my wife did most of the work. Next slide, please. So this is our sacred document when we look at ethics. This is what really distinguishes us from a trade and what makes us a profession, and that is our pledge as individual dentists to uphold the principles and the code of conduct. We often, when we talk about ethics, we want to use the word unethical, but I don't like to think that way. That kind of has a punitive sense. I like more to look at this as a guide, as a roadmap, if you will, that helps us reach the correct decisions when we have dilemmas in our world, and we're facing some now for sure. Helps us to come to the correct decision. You know, Charlie and both Cheryl mentioned that this is a really unique and different time, and we are certainly faced with looking at things in different ways than we're used to, adapting, relaxing some rules, bending some rules, and same is true with the ethics. Not that we relax the ethics, but we look at how we apply the ethics slightly differently in this time. But one thing that never changes is the core principles. Next slide, please. And this just shows real quickly what those 5 principles are. Let's go on, Greg, to the next one. So Charlie mentioned that the standard of care for telehealth, I'll say teledentistry, is no different than the standard of care for in-person dental care. That is what the law says. Next slide, please. And I would tell you this is what the ethics say. Same is true for the ethical standards. And let me just state right now, there is nothing that is inherently unethical about teledentistry. So if you're looking for that, I don't have anything to give you. All I will tell you is you maintain the same standards in teledentistry as you would for in-person care. Next slide, please. I love one-liners, and there's tons of definitions and interpretations out there of what ethics is, but this is one of my favorites, and it gets right to the point. You know, it's said that what is ethical is not always legal, and what is legal is not always ethical. For example, 4 weeks ago, Wednesday, when we were in the dawn of a new age, I was over at an extended care facility where I see patients, and I had a lady in extreme pain. She had an acute pulpitis. She was literally in tears. The tooth was really not restorable. She had no opposing dentition. So the solution was to take the tooth out. Now, at that time, Pennsylvania had put out a decree from their health department, which essentially shut down dentistry in the state of Pennsylvania. Unless you had a negative pressure operatory, you were not permitted to perform dentistry in the state of Pennsylvania. That lasted about 48 hours. And that doesn't exist anywhere in Pennsylvania. There is no negative pressure dental operatory. So as I was seeing this patient and I was aware of that, I just thought to myself, now what would I do this morning if I was in Pennsylvania? If I treat the patient, I'm in violation of the law. And, you know, I will say, although I don't want to preach civil disobedience to anybody, that if I was in Pennsylvania, I would have taken that lady's tooth out. Next slide, please. So we have these components of the ADA code. You've got the principles at the top, the code of professional conduct that kind of tells you what to do and what not to do. And then the advisory opinions are interpretations to specific situations. Next slide, please. There's two principles that I think everybody knows, even if you don't look at the code very often. One of them is this concept of doing good. And the main tenet of that is that the dentist has a duty to promote the patient's welfare. Next slide, please. And this is the other one, the do no harm. I think that is the single one that if you're ever quizzed, everybody's going to get this one right. But we want to avoid harm to the patient, harm to those who care for the affected person or the patient. That would be our staff, ourselves, harm to society. And also, let's not forget, we don't want to do anything to harm the integrity of the profession. Next slide, please. I just want to point this out. This will be coming out in May. I believe it's already out on the ADA website that Charlie mentioned. It's a really great synopsis, a one-pager of how to look at things from the ethical perspective and what we're doing and how we've had to change our practice modality. And as Charlie mentioned, there is a wealth of information, not only on the ADA website, but on the MSDA website. Both ADA and MSDA, and I too want to compliment Greg Buckler and the staff, have just worked 24/7 for the past almost 4 weeks now, keeping up with a rapidly changing world, a world when what happened 2 days ago is old news. And they've really, really done a great job of putting out the resources. Even though I'm hardly seeing any patients, I feel like I'm so busy just trying to digest all this material and keep up with it. So it's great reading. And if you haven't already, take a look. Next slide, please. So these are the goals, basically, as I see it. And of course, the number one goal, this is by general consensus of the ADA, the MSDA, the state board, all of the states, health departments, governors have put out the decrees that we are to only provide emergency and urgent care and defer the elective things. And that we want to contribute to mitigation, but I'm going to look at that in a slightly different way, or maybe use that term in a little bit different way. We want to contribute to the response, and I definitely put this one on the end. We want to emerge wiser and stronger, both as practitioners and as a profession. Next slide, please. So when we look at the ethics, we got to consider who all the stakeholders are. I don't need to read them. You can see there. These are all the people whose rights and privileges we want to consider when we weigh how we apply the principles. And sometimes the principles compete with each other, and sometimes the interest of individual stakeholders compete with each other. And I don't want to say the difficult part, but the thoughtful part of applying these is knowing how to weigh these things and figuring out how to weigh these things. And you don't always get agreement. The old joke is if you put 3 ethicists in a room together, the only thing that you can get just 2 of them to agree upon is the third one is wrong. Okay, next slide, please. So here's our big goal. And these are the principles that are going to apply to that goal. Next slide, please. So how can it be? We know the dentist has the duty to promote the patient's welfare. And we're so used to being a profession that strives to the level of prevention, the highest level of care, very rapid intervening when we see problems. So now we're going to tell patients, well, you're going to have to wait. How can that be consistent with that principle? But reality, it is very consistent with both beneficence to do good and non-maleficence to do no harm. Under number 1, we look at non-maleficence, do no harm. We're going to help with the social distancing. We're going to reduce exposure to our patients, to ourselves, and therefore to the rest of the community, because we're not going to send people out. We're going to do good by conserving the personal protective equipment for our patients that truly have urgent needs. And if we don't need them, we can donate them to other healthcare facilities or your colleague. For instance, if your practice has to close for whatever reason, maybe you've been exposed, maybe a practitioner has contracted COVID-19, they need their colleagues down the road to cover for them. If their colleagues don't have adequate gear, you need to share it. This is how we need to think. We typically think of the ethics kind of as inside the operatory between the dentist and the patient, but we really need to think outside of that box right now to the greater good of the entire community. Next slide, please. So emergencies, now we're going to look at the principle of justice, and I put some quotes up there. Those come straight out of the code, and it's very important to understand that we do have this ethical obligation. And I think even though I'm not an attorney, safe to say we have the legal obligation. We have to take care of our emergency patients. We cannot send them to the ERs. We cannot send them to the dental school. We cannot send them to the public health clinic, because these places, particularly the ERs, if we get a surge, they are going to be completely overburdened. And as Dr. Lerner pointed out, they're really not equipped to handle these dental emergencies anyway, most of the time. Next slide, please. So we're going to try to mitigate the mitigation with teledentistry. And as mentioned, we can triage the emergencies. What is an emergency? One definition is anything the patient thinks it's an emergency, but we all know that that's not always true. If you need a little help, go to the ADA website. They've done a lot of work trying to put together some good guidance for you. I think it's also very helpful to share that with any physician providers that sometimes might refer to you, and even with the patients if you want to put it on your website. Sharing of the records, really critical at this time. Like I said, if your office is down, somebody has to cover, you need to make arrangements for them to be able to see the x-rays, look at the history, look at the health history, so that they can effectively triage the patients using teledentistry. You can use this to provide continuing care for your patients, and you will be respecting, when you do that, the principle of non-maleficence, the section under patient abandonment. You're also going to be respecting the law when it comes to abandonment. You can monitor situations that could become urgent, and you can kind of stay on top of that and know when you have to intervene. That is certainly in the patient's best interest. Simply staying in touch with your patients, reassuring them. You can collect information to when you have to see a new patient, if you can collect that information remotely, their history, everything before they set foot in the office, you are reducing everybody's exposure. You're trying to observe the social distancing. And back a second to sharing and transferring. If you have to refer an emergency patient to a specialist or to another provider for any reason, and it's somebody that you have in your office, if you could set up a little session with them on Zoom or whatever, and while the patient is there, you could perhaps spare the referring provider, the provider you're referring to, that consultation visit, and then they would know when the patient walks in the door what they're going to do, what they need to do. They can be set up, and they're again reduce the amount of time that there is that close personal contact, and therefore reduce the chance of transmission. Next slide, please. So, we want to contribute to the response. We talked about conserving PPE, donating, not overburdening the ERs, but we can also volunteer. There's an organization whose name escapes my mind right off the top of my head, but it's like a reserve medical corps. We can volunteer. I understood that in some states, they've even considered emergency decrees to recruit dentists to work in hospitals, other healthcare settings. We want to be ready. Next slide, please. So under the principle of autonomy, how does this apply to teledentistry? The informed consent, this has been talked about, the protection of confidentiality. When I think about informed consent, I think it's also important for the patient to understand that there are limitations, and particularly looking forward past this healthcare crisis when we return to the new normal, whatever that might be. We don't ever want to be misleading with the patients about what we can and cannot do with teledentistry. And I can also see a world where, sometimes patients might be resistant to that, and we need to respect that as well. They really might want that in-person interaction when we know teledentistry would be adequate, but you always got to weigh the patient's right to make their own decisions. Next slide, please. So I'm just throw this in here because I think I haven't talked much about the principle of veracity, but which is being truthful. And that's where all the language in the code comes in about how you advertise. And I've seen some very clever things out there using teledentistry to telemarket. But I'm just going to read just a couple lines from veracity. That this is under the principle professionals have the duty to be honest and trustworthy in their dealings, communicating truthfully and without deception, and maintaining integrity, not represent care being rendered in a false or misleading manner. If you're going to try to engage patients, particularly patients you've never seen before through teledentistry, be sure that you're not going to be misleading on exactly what you can offer them. If you've not had an opportunity to collect the data that you would normally collect on a new patient intake, really think twice about whether or not you're going to bill for that, and if you're going to really consider that a limited exam or even in an emergency situation. And by the way, I didn't stress this, but even for patients that are not of record, you do have the obligation to treat those in an emergency situation or make arrangements for their care. So if somebody calls you, you've never seen them before with an emergency, you can't just say, no, I'm sorry, you're not a patient of record. Our practice is very limited right now. We're not going to see you. That would not be the ethical approach. You've got to do what you need to do to assess that patient as the best you can, triage them, and teledentistry is the tool to do that, and try to minimize the exposure to the office. Next slide, please. So this is a really critical time in our profession and our careers. We are all under a lot of stress and strain. I didn't say at the beginning, as I should have, that I have no conflicts with this, and I'm not really presenting any products or services, but I have the exact same conflicts that every one of us on this call has today. I've got the financial pressures of a practice that is virtually shut down, maybe doing maybe 5% of what we normally do, probably less than that. I don't even want to know what that number is right now. But my one-liner that I use is, if money drives the decision process, ethics will be compromised. And I just want to stress to everybody, as difficult as it is, try not to let the money drive your decision process on what you're going to do during this time. As difficult as that is, and believe me, I know, I'm in the same boat as everybody else. Next slide, please. So, I started into this. We want to emerge stronger. And I'm going to go back to the very beginning of the crisis and the response of organized dentistry, which I think is something that we can all be extraordinarily proud of. I think we'd be proud of how our benefit providers have responded, as highlighted in Dr. Lerner's presentation. Everybody is on board with this. Charlie mentioned how many practices from the Health Policy Institute survey are being compliant with the recommendations. But it's really, really important that we stay strong, we hold together, we cooperate, we remain ethical, because we will be judged as a profession for how we handle this crisis. And when we come out on the other end of it, if we do the right thing, we will maintain that special place of respect we have in society. And when we go to Annapolis to have the types of years that we've had, thanks to Charlie and our phenomenal lobby team, we will maintain the respect of those legislators, of our patients, of the community as a whole, and we will always be able to hold our head high and consider ourselves a profession. And I will also add, the most respected of all the traditional learned professions. Next slide, please. So here, this is my ending slide. And I want to give some special thanks as well. Nanette Elster, she's one of the staff people in my council. 3 or 4 of these slides, she gave me a whole bunch of slides. I told her I got to put something together quick. I just completely stole about 3 or 4 of the slides from her, and some guides. My entire council that I'm on, I reached out to them for any thoughts and ideas, and it's a wonderful council because we really all work together well. State Dental Association, I've already mentioned. Dr. Lerner, I've mentioned. Now the picture up there, you see I'm on the far right, and the orange shirt is Dr. Diego Maldonado, who's engaged to my daughter. Next to him, there's my wife. Austin Trask is my other daughter's boyfriend on the far left. And this is from last summer. We went out to Yosemite and had a wonderful time. If you ever want to get to know your children's fiancés well, or their significant others, I really suggest a trip like this, because you will get to know everybody very well. So we started this day out at 9,000 feet above sea level. We hiked out, ascended to just under 7,000 over some really rough terrain, and scrambled back up. And this was the reward we had. This was just under a 12-mile hike on a hot July day. We took turns carrying the load. We had some packs with provisions and the all-important water, which actually can be very heavy when you carry it on your back. But to do a hike like this, everybody needs about 1.5 gallons of water, because you really lose the water quickly. But we all stuck together. We all helped each other out. We shared the load when somebody got tired, and we had a spectacular reward at the end. And I just threw that up there as a little analogy to where we are right now. And I believe that if we do this, if we use our tools correctly, such as teledentistry, we as a profession will have a spectacular reward at the end. I want to thank everybody and for your attention and your time. And I know we got a lot of questions, so let's get to those.
All right, so we have about 30 questions so far, so I'm thinking we'll do about 10 minutes of Q&A. Any questions that we do not get to today, we will send to the presenters after the course wraps up, and we will then send those answered questions back to all of our attendees as soon as we have time to answer those questions. If you have any questions, please make sure that you are putting them in the Q&A box, not in the chat box. If you are typing in the chat box, those questions will not be recorded when we end this presentation, and we will not be able to answer those questions. So please make sure you are typing in the Q&A box. So I'll start with the first question. A new patient called and left a message about a toothache, but I have never seen the patient before. My office is closed. Should I prescribe antibiotics over the phone without seeing this patient?
Well, if you've taken the proper prescription class that's required, get a little echo, as a prescriber, you would not prescribe anything without seeing the patient. That being said, if you did a teledentistry appointment that it included an exam and a review of the patient's health history, medication, and you verified the patient's identity, remember this might be an opportunity for people to drug shop, then, and you're doing an antibiotic, I do think that that would be appropriate. As Dr. Wilson said, we have an ethical obligation to help the general public, whether they're patients of record or not. If you're uncomfortable with seeing a new patient, do a referral to a colleague who maybe has the time and energy to do the appropriate interviewing of the patient and prescribe the antibiotic.
All right, the next question. Is there a plan or date to open practices back up? Hopefully we can have a clear rule for Maryland.
I want to go a step back, and I didn't want to mislead anyone when I said the state board approved the course for license renewal credit. The state board does not, and generally for all courses, does not go in and approve the content for the course. So I just wanted to be clear on that. The other thing on opening up, I would strongly suggest you check daily coronavirus.maryland.gov. And I'm looking at that right now. We have 262 deaths in Maryland. There's been 27 in the last 24 hours. And there's a lot of graphic information. We have not reached the peak of the bell curve here yet. So as I said in my presentation, the call is up to our health department. It's not up to MSDA or ADA to decide. And I really don't think we're gonna even know this until we can't even anticipate a time until we see start a leveling and dropping off of that curve. This website updates every 24 hours. They just updated at 10 a.m. And we have in Maryland, we're approaching 9,000 cases, and that includes in the past 24 hours an additional 711. So I would say to everyone, please be patient. We've got to weather this storm all together, and MSDA will be in constant contact with the health department, and we'll get that information out as soon as we know.
question. Will the PowerPoint slides be available for attendees to review?
Yeah, some people asked, I saw other questions about the consent form. I think we can, maybe I'll talk to MSDA staff about putting the slides on our website so you can access them. People asked about the consent form. If you go to ada.org and then COVID-19, they actually have, and you take the 1 hour course, you can actually see and cut and paste, as I did for this presentation, the recommended one that the doctor had on there.
A follow-up question to that, can you provide a sample note for the teledentistry call?
I guess as in my slide, I would send when I email the consent form and information on arranging the teledentistry conference, just some general instructions and maybe a phone number. Not everyone is computer versed. I'm certainly not, and sometimes need help, and usually ask a young person, but you know, if they're having trouble logging in or seeing the picture, getting volume, you know, include in that sample note information like, okay, you can call me if you're having trouble logging in, things like that. The spoon tricks, having that, a phone handy to take photographs, proper lighting in the room. I can try to come up with something that would share all that information and try to share that with you. So I will work on that.
All right, the next question. If a patient texts or emails photos to you to follow up with a phone conversation, does that not count as telehealth or teledentistry?
That's just a follow-up from your teledentistry conference. So if you get a follow-up phone call, that is not a separate billable. You're billing for the original telehealth encounter, but if you do a follow-up phone call, you certainly note that in your documents, but it's not an additional billable thing. Now, if you set up the patient maybe not feeling better and you feel it's appropriate to do another telehealth conference with the patient on a different day, then that certainly could be billable. Whether that's payable by the insurance company, I don't know.
All right, next question. Is D9995 the billable code?
I think Cheryl answered this in her presentation, and she can verify this. You can attach a bill to that, but many carriers will not provide. As I said in my presentation, if you go to the ADA website, they update daily what the different carriers will and will not reimburse for. Cheryl, do you have any other comments on that?
All right, let's move forward. Can the D9995 code only be a video call, or can it be a phone call?
It cannot be a phone call. It has to be a face-to-face communication where you can question the patient and do a cursory exam over the computer.
All right. And Kara Lerner did write directly to us saying that the D9995 code carries no additional fees. She's having a hard time getting off the meeting, so I wanted to answer that for you. Next question. Can a dental assistant be the synchronous or asynchronous teledental provider and give the information to a dentist for review?
Yes, in my experience at long-term care facilities, the dental hygienist, dental assistant, the charge nurse, I get a lot of information and photographs from various healthcare providers, and conceivably can do a teledentistry conference with them. Many of these patients have chronic conditions where they cannot answer questions for themselves. So having a dental assistant who obviously not diagnosing, but maybe providing some photographs would be appropriate.
Great. All right. An additional comment before we jump into the next question. If you are looking to donate some of your additional PPE that you have, you can go to medicalsupply.drive.com in order to donate those. We also have some links on the MSBA COVID-19 page on where you can donate as well. Next question, can we use FaceTime or Facebook video for the teledentistry call?
Again, there's exceptions made in the HIPAA regulations during this crisis. This is going to change when we do get through the crisis. So I would start talking with some of your vendors. Some of you asked about particular names of vendors, and I particularly didn't want to name companies. But again, if you go to the ADA.com COVID-19 and do the video, they actually have a list where they provide contact information for various vendors that provide a variety of services in telehealth. Some do a lot of services, some integrate it with your current software. They integrate it on Facebook pages and your website page. So there's a variety of options, and you need to research that. I personally have SoftDent, and I kind of like the idea of integrating with my current software, especially when we're looking for e-prescribing. So, my first stop would be look at who your current software vendor is and talk to them. If they have programs, maybe consider that, and then maybe get 2 or 3 other quotes from other vendors and then decide which to do. But you need to be secure in that this is not an open forum currently where the public can see it. So that's the key question. That you don't want to open this up to potential HIPAA violation.
Do you want to wrap up the questions there, or do you want to answer one more before we wrap it up?
Well, I see the next 2 are kind of related, and it deals with crossing state lines or jurisdictions. And I thought this might come up. The law that, as we read in the Senate Bill 402 is passed, says a licensed healthcare practitioner. It doesn't say a Maryland licensed healthcare practitioner. So I think these are questions that I honestly do not know at this time the answer to. Say, for example, the practitioner practices in Maryland, but maybe lives in Pennsylvania, and they do the teledentistry conference from their home in Pennsylvania. What is the law pertaining to that? Does it revert back to the brick and mortar office or to their home? And this is just so new, we just don't know. So these are really good questions, and I think it's going to require some time to sort this out.
Charlie, and I'm not 100% certain on this, and this is new and certainly a legal question, but my understanding at this point in time is that you are practicing in Maryland, and even though your patients might be out of state, if they're seeking your care, you're in Maryland, then you function under Maryland law. Please don't take that as legal advice, though, because I'm not 100% certain, but I do believe that it does revert back just to that, you know, to the statement that the standard of care is the same as in-person care.
Right. We certainly have patients that maybe have a relationship with you and travel great distances to see you from out of jurisdiction. So the same laws would apply there as long as they're seeing you in Maryland. I guess the question comes to practitioners who maybe live in one jurisdiction, but their brick and mortar office is in another jurisdiction, and they do telehealth from their home. How does that pertain? And I think that's what needs to be ironed out.
Very good. But we are at 11 o'clock. We want to thank you, Dr. Doring, Dr. Lerner, and Dr. Wilson for your time this morning and information. I hope all the participants found it very useful and something to think about and grow from. Certainly there'll be more developments as we move past this COVID crisis and more permanent regulations are developed by the dental board and others. So I want to thank you all for participating. We will take the questions that we did not get to and post them, as well as a recording of this on our website.
There was one question, Greg, about CE credit. If you could just go over how they achieve that.
So we will, Alicia can clarify too. We will, when you end, we will automatically send within a day or two the certificate for the course to your email that you registered with.
Correct. And just to clarify, it will be going to the email that you registered for the session with. So as long as you signed up with your email, you will get your CE form within 24 hours sent to that email.
And the name on the CE will correspond with how you registered for this course. So if you did not register as your full and regular name, whatever you registered as what the form will identify.
If I could, there's one little thing I left out that I wanted to mention. Senator Kagan also sent her regrets that she couldn't be with us today. And she really appreciates what we're doing. And likewise, we appreciate what she's doing for us.
Very good. Good. Thank you all for your time this morning. Hope you have a great day, and check out msda.com/covid-19.php for this recording and all of our information about the COVID crisis.